Great pleasure to be here this afternoon. McMaster University, as I think you all know, derives some of its renown around the world for its focus on health and societal well-being. This is a reputation derived from our research intensity, our emphasis on the student experience, and our inventiveness in terms of that experience. Increasingly, I think we are building a reputation for our ability to build and to sustain partnerships, particularly within our community. And most recently, in the sway of the globalization of higher education, I should say the internationalization of higher education, to make an important distinction, we're trying to be thoughtful about the internationalization of McMaster and the development of appropriate international partnerships. This, of course, means that our faculty and our students travel far from campus frequently to widen their knowledge. And in fact, that is a specific requirement of the very successful Master of Global Health program, a program initiated in 2010 between McMaster and Maastricht University in the Netherlands by Dr. Baumann. It also means that we have many people from around the world come to our campus as learners and as teachers to widen our dialogue on vital issues facing our society. So this annual Chanchlani Global Health Research Award and Lecture has quickly become one of our most important events of the year. It is already known, I think, for its focus on today's most significant issues facing the health of people everywhere, and for bringing the best and the brightest minds from around the world to our campus to broaden and to enrich our understanding. So it is a great honor to welcome our special guest today, this year's award winner, Dr. Vikram Patel. I know this audience is as excited as I am to learn from his lecture and the discussion that will follow it this afternoon. I'd also like specifically to welcome Dr. Jaya Chanchlani and daughter Tina Chanchlani, both doctors, so your family, through your support of the Chanchlani Research Center and the establishment of this Global Health Award, is making an enormous impact, not only on this campus, but on our society across Canada and around the world. I want to say thanks for allowing us to continue the legacy of Vasu Chanchlani, after whom the award and the center is named, a man dearly missed by us all.
It's a great pleasure for me to introduce Dr. Vikram Patel, and especially I'm glad to welcome the Chanchlani family to join us today. Dr. Patel is a psychiatrist, a researcher, and an expert communicator. He is the Joint Director of the Center for Chronic Conditions and Injuries in the Public Health Foundation of India and Center for Global Mental Health at the London School of Hygiene and Tropical Medicine. He's also the founder of an NGO, Sangat, a mental health NGO based in Goa, which in 2008 won the MacArthur Foundation's International Prize for Creative and Effective Institutions. Dr. Patel's work spans a variety of disciplines, including epidemiology, medicine, psychology, non-communicable diseases, public health, substance abuse, and economic evaluation. His primary interest, however, is global mental health. His research has specifically focused on the treatment and care of people with mental disorders around the globe. In 2003, he wrote a book, Where There Is No Psychiatrist, a mental health care manual primarily used in developing countries by non-specialist health workers and volunteers, and has since been translated into 15 languages. Dr. Patel has been the recipient of many awards, including most recently being named in 2015 by Time magazine as one of the world's most influential people. Please join me in welcoming Dr. Vikram Patel.
Thank you, Sonia. Well, good evening. It's incredible to see such a full house for a lecture on mental health, and I think I'm going to be speaking to a very friendly audience. I'd like to start, first of all, by thanking the committee that made the selection for this year's Chanchlani Global Health Award for choosing me. I have seen the people whose footsteps I follow in, and it's truly a great honor and a privilege to be invited to speak here today and to be a recipient of this award. I'd also like to acknowledge and thank the members of the Chanchlani family for your generosity to support global health research, something that I strongly champion. My talk today is about the black dog. Now, when I asked Doris, who was helping organize this particular event, she asked me, a lot of people were wondering what in heaven's name was the black dog. And I guess many of you will be wondering, although I guess most of you, if you didn't know, you've probably gone up into Google and checked what it was. The word black dog, historians have actually debated quite a bit about the origins of this term. Who was the first person to actually use this metaphor? And I think the general consensus now is that it was first coined by the English writer Samuel Johnson more than 200 years ago. In his writings, he used the term black dog to describe periods of his life in which he became literally black in his mood. He was melancholic and miserable. And this particular excerpt from one of his writings very nicely illustrates his use of the term black dog. When I rise, my breakfast is solitary. The black dog waits to share it. From breakfast to dinner, he continues barking, except that Dr. Brocklesby, for a little, keeps him at a distance. Night comes at last, and some hours of restlessness and confusion bring me again to a day of solitude. What shall exclude the black dog from a habitation like this? It was after Samuel Johnson first coined these particular words that a number of different people started using the black dog as a metaphor for periods of very low mood. But it has to be admitted that perhaps the most famous person who actually used this term, and really who is credited for this term, is this man here, Britain's wartime Prime Minister. Churchill used to describe similar episodes in his life in which he experienced the black dog. Periods which appeared mysteriously, sometimes without any provocation, sometimes with due provocation, for example, when he lost the naval battle in the Dardanelles. Periods that could last weeks, sometimes even months, in which he would become extremely melancholic. He would lose interest in things, including, incredibly for Churchill, going to Parliament. Some historians actually, some biographers, in fact, credit some of Churchill's most amazing predictions to his black dog, particularly his prediction about the grave threats that Nazi Germany posed to the rest of Europe. However, the black dog was mostly very crippling for Churchill. He described it in very painful ways. He described it also as a medical affliction. He describes having consulted a doctor for the black dog, much like Samuel Johnson did 200 years before. However, he never received a formal diagnosis of depression, even though the features that he describes of the black dog would be instantly recognized by any mental health professional today as being similar or identical to what we might call depression. Even though Churchill never received a formal diagnosis of depression, I would not be surprised if indeed he suffered from depression. The reason is that depression is one of the most common health conditions, not just one of the most common mental health conditions, which of course it is, but one of the most common of any health condition to affect human beings. Just how common? Well, let us for a moment imagine a room full of 20 people. Over the last 5 years, Ferrari and her colleagues working in the Global Burden of Disease team in Queensland have been pulling together all the epidemiological literature on the prevalence of depression in populations. And they found an amazing nearly 200 studies that they could draw upon. 200 odd studies from more than 50 countries around the world. And examining this large body of evidence, they've estimated that the prevalence of depression globally is roughly 5%, or 1 in 20 people in this particular room. Now, let me try and give you some context to that proportion. I live in a country of 700 million adults. If I had to apply this prevalence rate to my country, it would mean that the equivalent of the entire population of Canada would in fact, at this point in time, be suffering from a major depression. Now, these are huge numbers, and of course, they can cause heart sink in most of us when we think about this giant morbidity. What we really want to see is whether we can do anything about this morbidity. Are there, in fact, interventions that can either prevent or treat depression? Over the last few years, I've been working as part of the Disease Control Priorities Group, which is funded by the Gates Foundation and involves a strong partnership with the World Bank, to examine the interventions that can be used by governments for mental, neurological, and substance use disorders. The aim of this particular initiative is actually to identify not only interventions that work, but interventions that are cost-effective. And so we can recommend governments to begin to invest in these interventions for scale-up. In a couple of months from now, we will release the results of our work at a meeting at the World Bank in April, which really synthesizes our recommendations across a broad range of human health conditions that affect the brain and mind. What really matters for the purpose of my talk today is to reflect on what our recommendations are for mood and anxiety disorders. We report, through the systematic review of the evidence out there on effective and cost-effective interventions, that there are interventions that are ready and should be scaled up, both for the prevention as well as for the treatment and care of persons with depression. Interventions that include psychological and social treatments, as well as drug treatments such as antidepressants, and for a few people with very severe and refractory depression, modified electroconvulsive therapy. So, we actually have good and strong evidence about the burden of depression, but we also have good and strong evidence about effective and cost-effective interventions that should be scaled up. Now, you kind of think, with this twin body of evidence, that the majority of people with depression will now be receiving these interventions. So we set about to ask the question, really exactly how many people with depression in any population are actually receiving one or more of these interventions that science shows us can transform their lives. One way of doing that is by estimating what is known as a treatment gap. That is to say, the gap between the number of people in any population who could benefit from a particular health intervention and the proportion of those people who actually receive that intervention. There's been quite a bit of research on the treatment gap, most of it from high-income countries. And that research shows that the treatment gap, even in the richest countries of the world like Canada, approaches 50%. However, the treatment gap in the developing world is much, much higher. Along with colleagues in China, we have just recently completed a systematic look at the evidence on the treatment gap for the whole range of mental health conditions in these two countries, which together account for nearly a third of the world's population, and have found that fully 90% of people with major depression in India and China do not receive the interventions that the Disease Control Priorities Program has recommended for scale-up. And mind you, India and China are actually relatively well-off countries when it comes to the developing world in terms of both financial and human resources for mental health or more general health care. These are staggering rates of a treatment gap. Most of us would be horrified if we saw these sorts of treatment gaps for any other somatic condition. And it has always been a mystery to me why we're not equally horrified when such figures are presented for a mental health condition. There is not that much new in these numbers. Actually, we've known about these large treatment gaps for quite a long time. It's been really for 2 decades now that I have sought to try and unpack and understand why is it that across society we seem unmoved by the fact that the majority of people with mental illness do not receive the care that science and medicine has shown can improve their lives. So my story today is to really unpack some of those reasons and to then demonstrate what science teaches us that challenges some of those myths and assumptions about depression and what impact that might have had on the generosity of governments to improve the quality of care for people with depression. One of the first barriers I encountered when I started working in Zimbabwe as the first part of my global health career in the mid-90s, and then I moved to India in the mid-90s after completing my training in Britain, was the idea that depression was not a health condition at all. And I can understand why people have this feeling, this nagging doubt that this is just the medicalization of social suffering. Because there is no clear dividing line between the misery of everyday life that is almost normative when you face great adversity and what we might consider a clinical condition. Many people would argue that what we call depression is simply the misery of difficult lives. Others have a very different argument that I encountered, which is to say that depression is a luxury for poor people, and even more so for poor countries. It was almost as if the right to have mental ill health was only contingent on the fact that you were materially well off. While you were materially poor, it was only your physical health and your social deprivation that deserved any attention. And then yet there were other arguments that because depression didn't really kill, and global health had far more important priorities, conditions that killed, it did not deserve our attention. Over the last couple of decades, colleagues in the field of global mental health and myself have really sought to generate evidence to examine these assumptions. We didn't believe many of these assumptions, but it was important for us to generate the science that examined these assumptions empirically. And there is now a very big science out there that demonstrates that all of these assumptions are false. First, let us look at the issue about whether or not this is in fact a genuine health condition by examining the impact that depression has on the burden of disease globally. And for this, I will refer to the global burden of disease work led by the University of Washington in Seattle, where the burden of disease is measured in a number of different ways, but the metric I will use today is the metric of the DALY, Disability Adjusted Life Years, which is a combination of the impact of a health condition on mortality, as well as on the quality of life lived. In 1990, the Global Burden of Disease group were the first to demonstrate the very large impact of depression on the burden of disease both in women and men. In women, almost 2% of the overall burden, and this is of all health conditions put together in the same pie, as it were, 2% of the burden of disease in women was accounted for by depression, and nearly 1% in men. About 2.5 decades later, this proportion has gone up by more than 50% in both genders. This condition is not only a leading cause of the burden of disease in both genders, but is in fact rising as a proportionate cause over time. A second assumption or a myth has been that depression is really not a disease or a health condition that affects the poor. Social epidemiologists have examined this association, but commonly in prevalence studies in which people have examined what is the risk associated with depression for people who have social disadvantage. And almost all the evidence, and the evidence exceeds more than 100 population-based studies from around the world, has shown that there's a strong and a positive relationship between poverty and depression. And there are several plausible mechanisms to explain this relationship. The first and most obvious mechanism is that people who live in conditions of poverty, and of course poverty is the mother of many health conditions. Poverty itself doesn't directly cause, say, for example, TB or indeed any other health condition. One has to examine the correlates of living in poverty, risk factors that might plausibly connect or cause a health condition to understand why there is a strong association between poverty and depression. So here you can see some examples of exposures that are associated with poverty, which, through a variety of different pathways, like social exclusion, can lead to depression. Not only an increased risk of depression, but also an increased risk of more severe forms of depression and more chronic forms of depression. This is often called the social causation pathway, poverty causing depression. But the relationship is more complex and bidirectional, because when you're depressed, one of the most important things that happens is that you lose energy. You feel fatigued all the time. And a direct consequence of this loss of energy, both physical as well as mental in terms of concentration, is impaired productivity. And in countries like India, where a large fraction, in fact, the overwhelming majority of people live on day wages, being unable to work for a single day often means you will not earn for that day. And so you can begin to see a different pathway that explains the relationship between depression and poverty, which is the social drift pathway. By being depressed, you earn less, but you also spend more on healthcare, which is often unresponsive and mostly in the private out-of-pocket sector. And so you get a classic vicious cycle between poverty and depression. So here we have the second important body of evidence challenging the myths about depression. The third body of evidence examines the impact of depression not only on the person who's directly affected, but also on other people that you live with. And perhaps the best example of the impact of depression on others is the impact of depression in a mother on her newborn child. Over the last 10 or 15 years, many research groups, including my own in India, have been specifically asking the question, what exactly is the relationship between depression in a mother and the growth and development of her newborn? We knew from the West that there is a very high degree of risk in mothers who are depressed for their child to have a variety of health problems, including accidental injuries. We asked ourselves the question, is it plausible that if a mother is depressed in a much more deprived environment where even the basic survival of the child and the nutritional survival of the child in particular was under threat, is it plausible that there is an association between undernutrition and stunting with depression? We now have a systematic review that has synthesized evidence from 17 studies involving 14,000 dyads from 11 developing countries that tells us very clearly what that risk is. The risk is 50% greater for a child to be undernourished in the first year of life if his or her mother was clinically depressed during that period. And the risk is 40% greater for stunting. We also now have a very strong body of evidence demonstrating the relationship between depression in mothers and delayed cognitive development. And of course, that in turn leads to further disadvantages when the child grows up and has underperformance in school, which in turn leads to poorer opportunities in employment and fuels the intergenerational cycle of poverty and disadvantage. So here we have an example of strong evidence about how depression affects other people, not just the person who is depressed, but also other people who live with that person. Still, there is a nagging doubt in those who want to prioritize depression, who feel that depression should not be prioritized in global health, and that is that depression doesn't really kill. And if we had to really look objectively at the evidence on mortality associated with depression, and again we would turn back to the Global Burden of Disease group, those naysayers actually have a good point. Because this chart shows you how many people are attributed to die due to depression. Exactly correct. 0. This is, of course, because the way the Global Burden of Disease estimates the specific causes that you can attribute a death to relies on death certificates. And no one would have on their death certificate that they died because they were depressed. Typically, there will be a far more proximal cause that will be attributed for the death. So, for example, no suicide is attributed to depression. Most of us would, of course, find this quite an absurd situation. And so we worked with the Global Burden of Disease group for the Disease Control Priorities Project to ask them to look at a different way of estimating the deaths that could be attributed to depression by looking at excess mortality. That is simply to say, what is the excess mortality in people who are depressed using a counterfactual situation of looking at mortality in that group, did they not have depression? We come up with a very different and staggering number. Nearly 2 million people could be attributed to have excess likelihood of death simply on account of the fact that they had depression. So now we have evidence that depression is a leading and a rising cause of the burden of disease, that it is strongly associated with poverty and social disadvantage, that it affects others around you, including a strong association with childhood undernutrition and stunting, which is a global health priority. And if we attribute a significant proportion of deaths of suicide and some cardiovascular deaths to depression, it accounts for nearly 2 million deaths each year. Of course, while we scientists were collecting all this evidence, writers and artists already knew that depression was a very lethal condition. In spite of all this evidence that comes both from science and the arts, there was still very little action from the global health community. I started then examining why is it that epidemiological evidence, such as what I have just synthesized for you right now, seemed to have such little impact. It seemed then at that stage that a new argument was made. That new argument was, it's all very well that depression's common, disabling, associated with poverty, etc., but it's no good, this kind of evidence, because we do not actually have enough mental health human resources to actually deliver the interventions that you say people will need. We don't have enough psychiatrists and psychologists and other mental health professionals, and even if we did, we can't afford them. So the global mental health community set about now generating a new kind of science. The science that tried to examine how we could deliver the treatments that we know work in resource-scarce environments. And what we did was we looked around us at other areas of global health, like maternal and child health, and looked at how they were doing the same, addressing the same kind of barrier. How, for example, were people delivering interventions to save newborn lives in places where there were no pediatricians? And we realized that the real innovation that these other global health innovators were focusing on was the idea of using community health workers, something that was called task sharing, identifying available human resources in the community and training them to provide life-saving, evidence-based interventions. And that's exactly what the last decade of global mental health has focused on. Using ordinary people to deliver psychological interventions that we know are effective for depression. These three examples of landmark trials, one carried out in Uganda, one in rural Pakistan, and our own trial of a collaborative care in India, demonstrated, these were the earliest trials that demonstrated the effectiveness, and in the case of our trial in India, the cost effectiveness of using community-based non-specialized workers, something that some innovators would call lay counselors, lay because they have no prior health training, but then they are trained to provide a specific package of psychological and social interventions for people with depression in community or primary healthcare settings. And the trials showed that not only were these approaches safe, but they were also extremely effective. The central one, the one from Pakistan, focused on maternal depression. And I think it's a really important example of an intervention which was in fact delivered by routine maternal health workers of the public healthcare system in Pakistan, but also because they were able to demonstrate not only the impact that it had on improving recovery rates from depression in mothers, but also, very importantly, improved child health outcomes, proving therefore that the observation that was made showing the association between maternal depression and poor child health outcomes was in fact a genuine causal one, because when you treated maternal depression, you also led to improved child health outcomes. Since these early landmark trials, there's been a mushrooming, a flowering of evidence on task sharing, not only for depression, it has to be said, for a range of different mental health conditions from around the developing world. One of my PhD students, Nadia van Ginneken, put together a systematic review for the Cochrane Group that examines the evidence, and we identified more than 30 randomized controlled trials in 2003. More recently, another systematic review has specifically sought to examine the evidence for postnatal depression and identified 6 or 7 studies from a variety of developing countries using non-specialized providers. And I want to just draw your attention to this a summary estimate in this forest plot. What that summary estimate shows us is that there is a 40% reduction in the prevalence of depression in mothers in those arms of trials in which the mother received a psychosocial intervention delivered by a non-specialist health worker compared to usual care. We now also have ways of understanding how we can deliver these interventions in routine healthcare settings. We now know that frontline health workers can deliver psychological and social interventions. Collaborative care is teaching us how these non-specialized workers can work within general healthcare settings, how they can be part of a routine primary healthcare team. The MANAS trial, which I alluded to a little earlier in my talk, is the largest trial of collaborative care seeking to integrate the management of any chronic condition, it has to be said, but in this particular case, depression, in routine healthcare settings. The trial was carried out in the state of Goa, in India, on the west coast of India. It was an effectiveness trial in which we randomized primary healthcare clusters into two arms. Those that received the collaborative step care, and I'll show you in a moment what that intervention looks like, and compared that with enhanced usual care, in which physicians were given information about the diagnosis of depression or anxiety, and also provided guidelines on how to treat it. This is what the intervention looked like. The package started with screening, a very key element of identifying people with a chronic condition, proactive screening. Those who were screened positive for depression were provided a step care intervention that was based around the severity of their depression. Everyone was given basic lifestyle advice and education about their symptoms. Those who were more severely depressed were either offered medication or a psychological treatment. Those who did not respond were offered a combination. And those who were extremely ill in the final step did not respond to any of the previous steps, or who were suicidal were referred to a specialist. This is a classic step care algorithm. 3 important health workers were involved. The case coordinator or the lay health counselor managed the overall coordination of care for that individual, but also provided all the psychosocial interventions. The primary care physician was concerned with providing the antidepressant medication when indicated in the second step. And the mental health specialist provided overarching supervision and support to the primary healthcare team, including providing consultations for those individuals who had severe mental health problems and reached step 4. Here are some images of the trial in progress. These were often health centers in which there were very few rooms available. So one of the key elements of actually running this program involves setting up these sorts of small porta cabins that afforded at least a modicum of privacy for the case managers or the counselors to provide psychological treatments. You can see one of the counselors in the photograph on the top. And a very key element also of the whole program was to raise awareness about this mental health intervention in the primary health centers, because mind you, we were working in a setting where mental health care had never been provided in any of these clinics, where there was almost no awareness about depression as a health condition. And so we also had to be able to introduce the idea of a mental health care intervention without it being attached with stigma. And one way we did that, apart from the posters that really illustrated what was going to happen in that clinic, was to introduce yoga as a more broad mental health promotion intervention that was very widely acceptable within this community, and therefore also helped destigmatize the role of the counselor. In these images, you can see the collaborative care element really well demonstrated. All of these images show various kinds of partnerships in progress. For example, in the bottom right-hand section out here, the photograph here, you can see the psychiatrist visiting one of the primary health centers and discussing with the primary care physician the management of cases of depression and anxiety that he had seen in the previous month. The psychiatrist would visit the clinic on a monthly basis and oversee the quality of the program, and also provide joint consultations for people for cases who are very severely ill. So we did this trial, and then we really wanted to examine both the effectiveness as well as the cost effectiveness of this approach. We wanted to ask, not only was this particular program effective, but because there was an additional economic implication, we were putting in a new human resource in these clinics in the form of this lay health worker. Admittedly, this was a person who cost very little because they were recruited from the local community and had no prior health training. But still, there was a salary attached to it. There was a resource implication of training. And importantly, we had a mental health specialist who was now going to provide supervision. And there was therefore also a resource implication attached to that. So we also wanted to ask a very important policy question, was about cost effectiveness. So in this slide, I summarized the main findings of the effectiveness of the intervention. This is a relatively low-intensity intervention, and we found a 30% decrease in the prevalence of the disorder over a 12-month period, a 36% reduction in suicide attempts and plans. Suicide attempts are an extremely important public health problem in India, which is often described as a country with one of the highest suicide rates in the world. But perhaps from a social outcome perspective, what was really important for us was a demonstration that those individuals with depression and anxiety in the intervention clusters had much fewer days out of work than in the control arm clusters. So improving depression through this intervention also was associated with improved functional or social outcomes, which is so very important in the context of breaking the vicious cycle between poverty and depression. Our economic analysis showed that the intervention, even though there were more direct costs of providing the intervention, was actually associated with reduced healthcare costs. And the reason, of course, was that people got better. People got better quicker, and so they stopped coming to the clinic. They stopped using doctor time, they stopped using medical resources, and as a consequence, from an overall health system perspective, there was actually overall reduced costs. And from an economic perspective, for those of you economists, I'm sure you will see what I mean by the word dominant here. Simply means that if an intervention produces clinical benefits and is actually cheaper, it's a no-brainer. There's no point doing any more statistics, because in fact, it is a cost-saving effective intervention. So, there is now a large body of evidence demonstrating not only the use of this approach for depression, but for a whole range of mental health conditions. You might now think, with all this evidence about the burden of depression, the impact it has on people's lives, the impact it has on others, the excess mortality associated with depression, the fact that we have effective treatments, and the fact that we can deliver these treatments using available human resources in routine primary healthcare settings, this would surely unlock the treasury. Now, we would definitely see some amount of funding and supporting of these sorts of interventions in global mental health, particularly in the poorest countries of the world. Is that the case? With colleagues from Harvard, we looked at the database that is available that examines how rich countries are contributing to development assistance to the poorest countries in the world. This database allows us to unpack not only how much money is being donated by countries like Canada and the US, for example, to countries like Togo and Niger, but it also allows us to examine what are the priority areas that this money is going towards. So with colleagues from Harvard, what we did was we really looked at this database and asked the question, well, two questions. How much money is being given in absolute terms towards mental health in the poorest countries in the world by the rich countries through development assistance? But we were also very interested not only to look at absolute amounts, but proportions. That is to say, out of every dollar that is being donated as aid towards development assistance for health, what proportion is being specifically given for mental health? And this is what we have reported. In the year 2007, which we use as a watershed year, mainly because that was the year when the Lancet Medical Journal produced a series in global mental health, which really was a very important watershed for the field. Since then, we found a threefold increase in absolute amount of dollars that were being given in development assistance to health, specifically for mental health. This was a very reassuring finding. However, the proportion tells a somewhat different story. Even in the best year of all, in 2009, it was still less than 1% of the total development assistance for health. And actually, the latest indications since 2012 suggest that the proportion has fallen further, no doubt in part because of Ebola, which has actually also then attracted a very large amount of the development assistance for health, which is not necessarily new money. It's actually the same money that was available for other areas, but which has now been diverted to address the Ebola epidemic. So it seems to me, friends, that these last 2 decades of research has really been pretty useless. Because I and my colleagues have spent 2 decades trying to make the case for more public spending on mental health. We have tried to approach the various assumptions, the various myths around mental health in a variety of different ways, using observational epidemiology, using efficacy studies of specific interventions, using effectiveness studies where we attempt to deliver these interventions using available human resources, to no avail. Because it seems really that no one cares about the mental health sector. And that science alone isn't going to actually change hearts and minds. I had to then really fall back to try and think about why is it that policymakers and wider society simply doesn't care. And I guess you all probably know the answer. It seems to me that it isn't really the science about burden and effective interventions that matters. It is really about how do we change the hearts and minds of people who simply do not care about mental illness because of the stigma attached to mental illness. This stigma is very profound. It's very deep-rooted. It's very pervasive. It pervades every aspect of policy making. It pervades every aspect of society. It is because of this stigma that we continue to tolerate discrimination at all levels of society, from how much money a health minister might give to mental health, to the kinds of ways that people with mental illness are treated in general hospitals, to the quality of care that people with mental illness receive in mental health care institutions. It is the kind of stigma that can explain why the world is silent when you see the violation of basic rights of people with mental illness. And by basic rights, I don't mean only the right to humane care, but the right to actually live a life with dignity and freedom. Many of these images are very recent, and in many ways they display not only a complete denial of basic rights, but much worse, in some cases, frank torture. These are modern images from around the world that show how hospitals and communities are addressing mental illness in the absence of any humane alternative. Of course, I was intrigued, in every city of the developing world, you will see images such as this. But I was fairly intrigued to see an image just like this last night when I returned to the Sheraton Hotel in Hamilton. So it's very clear, obviously, that people with homeless people with mental illness aren't purely seen on the streets of poor countries. It does seem to me that it is the stigma of mental illness that we really do need to address. For, as we've argued in a number of places with my colleague and mentor Arthur Kleinman from Harvard and I, that we need to move beyond science and beyond evidence if we're really going to achieve a better deal for people with mental illness around the world. We've called it the moral case for international mental health, and Arthur Kleinman has argued that this scandalous situation in which the science is being completely ignored is nothing short of a failure of humanity. I'd like to end by drawing inspiration, though, from another global health problem. Clearly, mental illness isn't the only global health problem that has suffered historically from stigma, but it is the one that has perhaps most persistently been unable to shake that stigma off. We can look around us and think of many other very inspirational stories of global health where diseases that were very stigmatized have transformed in their public image. And of course, the best example of all comes from HIV/AIDS. I can still remember in the mid-90s being a young doctor working in Zimbabwe, which was at that time the epicenter, and actually still remains the epicenter of the HIV pandemic in Southern Africa. At that time, I can remember these extremely vociferous debates that were going on in global health. Global health as a discipline actually didn't exist then. There were these passionate debates. On the one side, you had the evidence, the science showed us that HIV/AIDS was a deadly disease. But a combination of medicines could transform this deadly disease into a chronic condition. And on the other side, you had people from governments in rich countries, governments in developing countries, pharmaceutical companies, and even the World Health Organization saying that whereas these medicines were by right available to people living with HIV in rich countries, they should be denied to people in Africa and Asia because the healthcare systems were not prepared to deliver these interventions. These interventions required long-term care. There was a risk of resistance if people did not take these tablets regularly. The healthcare systems were barely struggling to provide acute care for things like malaria. That there was not enough money in the system, and that if HIV care was made available to the millions affected, it would suck all the money out, the little money that was left, and so therefore all the other health areas would be completely neglected, etc. Many of you will remember those discussions. However, that situation has transformed. What was once a feared, deadly disease, where people who were affected by this condition were stigmatized. In India, for example, some of them were imprisoned because of the fear that you might catch HIV/AIDS by proximity to someone living with HIV/AIDS. We've come a really, really long way. Around the world today, people living with HIV have the right to care, not just the right to first-line treatment, but the right to second-line treatment as well, for free, provided through the public healthcare system, close to their own homes, through HIV clinics built in district hospitals. There is an empowerment of people with HIV with firm legislation to protect them from discrimination and stigma around the world. Vulnerable groups like men who have sex with men and intravenous drug users are gaining more and more space within civil society on account of the empowerment of their rights, for example, to receive humane and dignified care. And when I look at this remarkable story, because it is truly remarkable, somebody once wrote that the HIV story probably represents the most remarkable global health success story of our times, I realized that science played only a very small role in making this transformation happen. Because remember, the science of safe antiretrovirals was known even as early as the late 1980s. It took fully 12 years and tens of millions of deaths later before these drugs were made available to the rest of the world. And that happened because scientists, people like us, stepped out of our comfort zones and worked very closely with civil society. We worked very closely with governments, with leaders in development. Where needed, we didn't only stop at trying to change hearts and minds, but we went as far as shaming governments that failed to act. But perhaps most important of all, we mobilized people living with HIV/AIDS to speak on their own behalf. I was most moved by the work of the Treatment Action Campaign, which on December the 10th, 1998, a day which is now celebrated as International Human Rights Day, and a very fitting day too, led by the charismatic Zaki Ahmad, a large congregation of people living with HIV/AIDS mingled together with academics, scientists working in the HIV sector in the streets of Johannesburg, and demanded from their government the right to care for people living with HIV. To me, this was just as powerful, just as important a step in the story of how we transformed HIV/AIDS from a deadly killer to a chronic condition in which the rights of people with HIV are now enshrined the world over. I guess we in the mental health sector must also learn from the HIV/AIDS sector. And certainly in my own work, this is the direction I'm now taking. I want to end by really reminding us, I started my talk about the black dog, and I referred to one European prime minister, and really drawing from the example of people speaking for themselves, I want to end with another European prime minister, and that's Mr. Kjell Bondevik. Some of you may know of Mr. Bondevik, twice Prime Minister of Norway. Mr. Bondevik, turns out, also lived with a black dog, except that he didn't call it the black dog. He called it plain old simple depression. But Mr. Bondevik is a remarkable man. He was twice Prime Minister of Norway. During his first term as Prime Minister in the late 1990s, when he started developing the modern equivalent of the black dog, he trotted off to his doctor and found out from his primary care physician that actually he was suffering from depression. Now, most prime ministers would probably try to hide that from their electorate, their people. But Mr. Bondevik wasn't going to have any of that. He went on national television and announced to his people that he was depressed. And so, like depressed people in Norway do, he was going to go off to his fishing cabin along with his wife antidepressant medicines and seeing a psychotherapist. And in the meantime, he was going to hand over the reins of his government to his deputy prime minister. So this all seems very Norwegian and normal, and that's exactly what he did. He went off, he recovered, he came back, and he became prime minister again. 2 years later, there was an election, and incredibly, Mr. Bondevik was re-elected with an even bigger margin than he was before. And in many ways, when I heard Mr. Bondevik, I had the privilege of meeting Mr. Bondevik and spending time with him and listening to him a few years ago at the World Health Organization. And this is what he had to say. Stigma is the main problem regarding our efforts to improve the mental health situation in our countries. I want to contribute to combating stigma, and therefore, I am here today to tell you my story. Indeed, I think the power of telling your own story is probably going to be the most important route towards improving mental health care for all. Thank you very much.